I'm mad as hell, yes, at the government. Because before the vaccines, before the mandates, before the political lines were drawn, there was a window, and based on early data, that window might have saved hundreds of thousands of American lives. Maybe more. By December 2020, before the mRNA vaccines were available, the United States had about 16 million confirmed COVID cases. 16 million. About 300,000 Americans had already died. Now imagine this. If early vitamin D optimization had reduced infections by 50%, as suggested by large U.S. observational data, that would have meant 8 million fewer infections. 8 million people who never got sick. Now take the remaining cases. If severity and death rates had dropped by 80%, similar to signals seen in early hospital data, deaths might have fallen from 300,000 to roughly 30,000, not 300,000, 30,000. That's a difference of approximately 270,000 lives. 270,000 mothers, fathers, grandparents, friends. How important would it have been to save half of your loved ones? Because when you say 50% reduction, it sounds academic. But when you say 8 million infections prevented, 270,000 lives saved, it stops being statistics. It becomes personal. If this is hitting you right now, if you believe public health should investigate every credible tool during a crisis, hit like. Not for me, for the algorithm, because YouTube only spreads conversations people engage with. Subscribe if you want serious, data-driven discussions about uncomfortable medical questions. And share this with one healthcare professional you know. Because this conversation should not stay in a comment section. Now let's talk about where those numbers came from. The massive U.S. study by Kaufman analyzed nearly 200,000 people early in the pandemic. Those with vitamin D levels above 50 nanograms per milliliter had roughly a 50% lower COVID infection rate, and lower death rates, compared to those who were deficient. That's not a fringe blog post. That's large-scale population data. Then came Spain. In early 2020, the world was shutting down. Flights grounded, schools closed, cities silent, hospitals were overwhelmed, doctors were improvising, fear was everywhere, and in the middle of all that chaos, something interesting was already sitting quietly in the medical literature. Vitamin D, not a miracle cure, not a fringe therapy, not a political symbol. Vitamin D, a hormone-like nutrient we've studied for decades. We know it regulates immune function. We know it influences inflammation. We know it affects respiratory health. This wasn't some obscure compound pulled from a jungle plant. It was basic biology. Then researchers started looking at real-world data. Dr. David Kaufman and colleagues analyzed nearly 200,000 U.S. patients. Let me repeat that. Nearly 200,000. They looked at vitamin D levels that had been measured before people were tested for COVID. So this wasn't people taking supplements after they got sick. This was baseline status. And what they found was striking. People with low vitamin D levels, especially under 20 nanograms per milliliter, had significantly higher positivity rates. Not slightly higher, significantly higher. Meanwhile, those above roughly 50 to 55 nanograms per milliliter, they had about half the infection rate. Half. Now pause right there, before anyone jumps to conclusions. This was observational. It does not prove causation. It does not prove vitamin D prevents COVID. It does not prove supplementation would change outcomes. Correlation is not causation. We all know that. But here's the thing. Observational data like this, especially with that sample size, is exactly how early warning signals appear. It's how hypotheses are formed. It's how smart systems respond. And at the time, estimates suggested that somewhere between 90 and 95% of Americans had suboptimal vitamin D levels. Think about that. If the signal was real, even partially real, that meant most of the country was potentially sitting in a higher risk category during a respiratory pandemic. So when a signal like that appears, you don't mock it, you don't politicize it, you don't shove it into a cultural corner. You investigate it aggressively. You launch randomized controlled trials immediately. You test different dosing strategies. You stratify by baseline levels. You answer the question as fast as possible. Because in a crisis, speed matters. Not reckless speed, scientific speed. If you agree that strong early signals deserve fast, rigorous investigation, comment, study it. Because this isn't about believing in vitamin D, it's about being willing to test. And that's what science is supposed to do. When I say talk to your doctor, I don't mean have a casual conversation and move on. I mean ask for a blood test. Ask for a 25-hydroxy vitamin D level. Not once in your lifetime. Yearly. Because what gets measured gets managed. Many clinicians consider levels below 20 nanograms per milliliter deficient. Some aim for 30 to 40. Others argue optimal immune function may occur at higher ranges, often discussed in the 40 to 60 nanograms per milliliter zone. There is active debate about whether levels up to 70 to 100 nanograms per milliliter are beneficial or unnecessary. That's exactly why we need large, definitive randomized controlled trials. Some researchers, including those cited in modeling analyses, have suggested that daily doses around 5,000 to 10,000 IU or equivalent weekly dosing can raise blood levels into higher ranges in many adults. But dose response varies dramatically by body weight, baseline deficiency, genetics, sun exposure, kidney function, and excessively high blood levels can cause harm, including hypercalcemia and kidney complications. That's why blanket dosing without testing is not responsible medicine. The responsible approach is test, supplement if appropriate, retest, adjust. And yet, despite 5 years passing since early signals emerge, we still do not have large-scale, definitive RCTs answering the core question: do optimal vitamin D levels reduce infection or severity in future pandemics? That absence is what makes me mad. Now, let's talk projections. And before we go 1 inch further, let's slow this down. These are not proven outcomes. This is not a claim that this would have happened. This is modeling, modeled scenarios, the same kind of modeling governments used every single day during the pandemic. To justify lockdowns, to close schools, to restrict travel, to accelerate vaccine rollouts, to shape economic policy. Modeling isn't prophecy. It's, if this signal is real, what might the impact look like? So let's walk through it calmly. Take 2 early signals, roughly a 50% infection reduction association from the Kaufman data, and roughly an 80% severity reduction signal using the Spanish ICU outcomes as a proxy. Again, associations, signals, not guarantees. Now let's plug those into real pre-vaccine US numbers. Through December 2020, about 16 million confirmed cases, about 300,000 deaths. So let's run a scenario. If infections were cut in half, that's 8 million infections potentially prevented. 8 million people who never get sick in the first place. Now take the remaining infections. If deaths among those cases dropped by 80%, instead of 300,000 deaths, you're looking at something closer to 30,000. That's a projected difference of about 270,000 lives. 270,000. Now stop. Breathe. This is modeling, not proof, not certainty, not a retroactive claim that this definitely would have happened. But here's the uncomfortable question. Why were we willing to model worst-case viral spread scenarios daily, but not equally aggressive best-case intervention scenarios for low-cost, biologically plausible tools? Governments used modeling to justify enormous societal decisions. Shutting down businesses, closing classrooms, restricting gatherings, all based on projected curves. So why not model vitamin D optimization at scale? Why not say, if this signal is even partially true, what's the upside? Because modeling isn't about ideology. It's about scenario planning. And when something is cheap, widely available, and biologically plausible, the bar for running the numbers should be lower, not higher. If you believe modeling should apply to inexpensive interventions too, share this video, because this conversation isn't about rewriting history. It's about asking how we respond next time. Quick break. And I mean that, quick. If this video is challenging you, good. It's supposed to. If it's making you pause, rethink something, question a narrative you assumed was settled, even better. That's how progress happens. Not through outrage, not through blind agreement, through thinking. So if you're into uncomfortable medical questions, if you want discussions that don't fit neatly into partisan boxes, if you believe science should stay curious, even when it's inconvenient, subscribe, because this isn't a one-off video. This is a series, and we're going deeper. Now here's the practical reality. YouTube doesn't push videos because they're thoughtful. It pushes videos because people engage with them. So when you hit like, you're not just clicking a button. You're telling the algorithm, more of this. More nuance. More data. Less tribal shouting. It sounds small. It takes half a second. But it genuinely helps this conversation reach healthcare professionals, policymakers, researchers, and families who are just trying to understand what happened. If this matters to you, engage with it. Now, back to the science. Now let's talk about who was actually dying. Roughly 80% of early COVID deaths occurred in older adults. Not young, healthy 20-somethings. Older adults, parents, grandparents, retirees. In the United States alone, about 76 million people are over the age of 60. That's not a small subgroup. That's a massive, clearly identifiable high-risk population. Now layer something else on top of that. Vitamin D deficiency is more common in elderly individuals, people with darker skin, individuals with obesity, people with limited sun exposure. And think about that last one. Limited sun exposure. Who has limited sun exposure? Nursing home residents, assisted living residents, homebound seniors. The very population we knew, early, was at highest risk. And what happened in nursing homes was catastrophic. Approximately 100,000 nursing home deaths before vaccines were available. After vaccines rolled out, around 40,000. That contrast alone shows how powerful targeted protection can be when applied to high-risk groups. So here's the uncomfortable intersection. If vitamin D deficiency was widespread in this population, and if even part of the observational severity associations were real, then this group should have been first in line for aggressive testing and supplementation trials. Immediately, because this is how risk-benefit analysis works. If you have high baseline risk, low intervention cost, low biological risk, plausible mechanism, early signal of benefit, you test it fast, even if the benefit turns out to be modest. When the risk is enormous, modest benefits save lives. In a high-risk population, a 10% reduction matters. A 20% reduction matters. Even a 5% reduction matters when tens of thousands of people are dying. That's not ideology. That's basic epidemiology. You focus on absolute risk reduction in vulnerable groups. You prioritize scalable, low-cost interventions while you wait for definitive solutions. And the question isn't, was vitamin D a miracle? The question is, was this population important enough to aggressively test every plausible layer of protection? Because in public health, sometimes small edges, applied early and widely, change the trajectory. And that's the part worth examining. Now let's talk safety. Because anytime we discuss interventions, especially at population scale, safety comes first. Vitamin D is generally safe within reasonable ranges. That's not controversial. It's been studied for decades. But generally safe does not mean unlimited. Extremely high blood levels can cause problems. Hypercalcemia, which is too much calcium in the blood, can occur at very high vitamin D levels. That can lead to nausea, confusion, kidney stress, and in severe cases, kidney damage. So yes, there are risks at extreme doses. That's why testing matters. That's why monitoring matters. And that's why serious discussions about public health interventions require medical supervision, not guesswork. Many clinicians consider blood levels between roughly 40 to 60 nanograms per milliliter to fall within a safe and potentially optimal range. But even that is debated. Some experts argue for slightly lower targets. Some explore slightly higher ones. And that debate? It should be resolved with large, well-designed randomized controlled trials. Not Twitter threads. Not cable news debates. Not podcast arguments. RCTs. Stratified by age. Stratified by baseline deficiency. Stratified by comorbidities. Clear endpoints. Clear dosing, clear monitoring, that's how you settle it. And let me be very clear about something. Talk to your physician before changing anything. This channel is about investigation. It is not about reckless self-experimentation. It's not about megadosing. It's not about bypassing medical care. It's about asking whether plausible, low-cost interventions deserve rigorous evaluation, especially during a crisis. Curiosity is not recklessness, but action without medical guidance can be. And we're not doing that here. Now zoom out for a second. This conversation doesn't start and end with COVID. Outside of COVID, observational research has linked adequate levels of several micronutrients to meaningful health outcomes. Vitamin D, vitamin K2, folate, also known as B9. And what are we talking about in those studies? Reductions in neural tube defects, small for gestational age babies, miscarriage risk, cardiovascular disease markers. These aren't fringe outcomes. These are life-altering, generation-shaping outcomes. Now, again, observational research does not prove causation. But here's what's important. We've already seen micronutrient policy work. Folate fortification is one of the clearest public health successes of the past several decades. When countries began fortifying grains with folic acid, rates of neural tube defects dropped dramatically. Not slightly, dramatically. That wasn't magic. It was biology meeting policy. It was identifying a deficiency, confirming causation through trials, and implementing a scalable solution. That's proof that micronutrient strategy, when supported by solid evidence, can save lives at population scale. So when researchers discuss broader theories, like optimizing D3, K2, and B9 together, it's not irrational. It's a hypothesis, a biologically plausible one. But here's the key. The broader D3K2B9 theory needs causation-level trials. Large ones, well-funded ones, multi-center randomized controlled trials that move beyond association and answer the question definitively. Because if it works, even partially, the implications are enormous. And if it doesn't, then we rule it out and move on. That's how science is supposed to function. Which brings us back to the same frustration. The same recurring question. If these signals are biologically plausible, if micronutrient policy has worked before, if the interventions are inexpensive, why are we not funding the trials needed to settle it? Why are we comfortable debating it endlessly, but not resolving it decisively? That's the real issue. Not belief, not ideology, investment in answers. Proposals to increase D3, K2, and B9 fortification? They're bold, and they should be. Population-wide fortification isn't something you do lightly. Because when you fortify an entire population, you remove individualized dosing. You're no longer adjusting for one person's deficiency, one person's absorption, one person's baseline risk. You're making a blanket intervention. And that demands caution. So any expansion of fortification programs should include rigorous safeguards, national blood level monitoring, to make sure we're hitting targets safely. Hypercalcemia surveillance, because too much vitamin D isn't harmless. Phase-based increases, slow, measured, data-driven rollouts. Transparent reporting, so the public, clinicians, and researchers all know what's happening in real time. That's not theoretical. We should be capable of it. We already track population-level health metrics all the time. Cholesterol levels, diabetes prevalence, vaccination rates. We even monitor drug safety at the national scale. So here's the question. If we can track all of that, why not vitamin D status, more aggressively? Especially when deficiency is widespread, the interventions are low cost, and the potential upside is massive. It's not radical thinking, it's basic public health logic. And that's the conversation we need to be having, urgently, clearly, and responsibly. Earlier I said I'm not mad at politicians. Let me clarify, I am mad at policymakers, on both sides, for not prioritizing large-scale trials of inexpensive, biologically plausible interventions during a global crisis. It has been over 5 years. We funded massive vaccine trials. We funded therapeutic trials. We funded stimulus packages. But we did not aggressively fund definitive D3K2 trials at scale. That's a policy failure, not a conspiracy, not evil, but a failure of prioritization. Randomized controlled trials are the gold standard of evidence-based medicine. They are the studies that prove whether something truly works or not. But they are also expensive. A properly designed randomized controlled trial usually costs between $10 to $20 million to complete. Pharmaceutical companies are often willing to fund those studies when they can patent a drug and recover their investment. But vitamins cannot be patented. That means there is little financial incentive for private companies to fund large trials on nutrients like vitamin D. That leaves the responsibility largely with governments and public health agencies to support these kinds of studies when the potential public health benefit could be enormous. And we could even design future vaccine studies that stratify participants by vitamin D status to see if outcomes differ. That's how layered science works. Not vitamins versus vaccines. Data versus uncertainty. Could optimized vitamin D status enhance vaccine response? Could it reduce breakthrough severity? Could it reduce ICU admissions independently? We don't know, because we didn't run the trials. And that is unacceptable 5 years later. I'm mad as hell, not because I hate medicine, but because I love evidence-based medicine. And evidence requires asking hard questions, even when the answers are inconvenient. Now, if this conversation about vitamin D and K2 has you thinking deeper, there's something else you should check out. There's a book called The Secrets of Vitamins D3 and K2 That Can Save Your Life by David Lee Grimes. It looks more closely at something we didn't fully cover today: the connection between vitamin D3, vitamin K2, bone health, hip fractures, and osteoporosis. And this matters, especially for older adults. Hip fractures are not just broken bones. About 20% of seniors who break their hip will die within 1 year. 1 in 5. Many of those deaths could potentially be avoided by preventing osteoporosis in the first place. In fact, current osteoporosis treatments can prevent up to 60% of hip fractures when they're properly used. That means the real opportunity is prevention before the fracture ever happens. This book explores how D3 and K2 may play a role in long-term bone health and why micronutrients deserve more attention in prevention strategies. If you want to learn more, the book is available on Amazon, and I'll put the link in the description below. And if you're interested in topics like nutrition, prevention, and evidence-based medicine, make sure you subscribe to the channel. Because we're going to keep asking the big questions. Are we using everything we already know? And are we investigating low-cost prevention tools aggressively enough? If you want to go deeper into vitamin D3 and K2, check out the book, and then come back here. Because this conversation is just getting started.